Welcome to Healthline 3. I'm Terri Simmons. Today we're talking with Dr. Antonio Pizarro of Willis-Knighton Pelvic and Reconstructive GYN Surgery. We're going to be talking about urogynecology and robotic surgery and all kinds of women's health. So be sure and call us. We'll be taking your calls throughout the show. And as a reminder, please make sure you're in a quiet room with your TV turned down low so we can hear your questions. The number to call is 318-219-4569, and you'll see it across the bottom of your screen throughout the show. Dr. Pizarro, thank you for being here.
Thank you, Terri. It's an honor. I appreciate it.
And I'm very excited to talk to you. We've been talking all morning about what you're going to be sharing with us today. So
Great.
First off, we mentioned urogynecology. So what is that exactly?
Urogynecology is a surgical subspecialty that deals with two aspects of women's health. On the one hand, it deals with the treatment of what we call pelvic floor disorders. And on the other hand, it deals with advanced or complex surgeries for non-cancerous conditions. Pelvic floor disorders refers to the idea that the pelvic muscles and connective tissue that support the uterus, bladder, and other organs in women, those tissues can become either they just don't work well or they're damaged. And of course, surgery refers to the types of procedures that can be undertaken for women for a number of conditions. And in my specialty, it's not it's important for us to add that it's for benign gynecologic or GYN conditions.
Okay. And just to tell a little bit about you also, you're board certified, right?
That's right.
And I know exactly for not only what it takes to be that, but to even go through all of the documentation. I mean, it's a really it's an in-depth process to have this, so that's not just a feather in the cap. That's really something to be board certified.
Well, thank you. I am board certified in both obstetrics and gynecology and also in urogynecology. Mm-hmm. Board certification, as you described, refers to a process where a governing board, and in our case the American Board of Medical Specialties and more specifically American Board of OB/GYN, has a sort of a rigorous process of reviewing at the beginning the cases, the type of surgeries you've done, and you have an oral exam to sort of justify why you've done it that way, justify your practice patterns. And they also, as part of the oral examination, ask you a bunch of different complex questions. You also take a written test. And in my specialty, I can't speak for other specialties, but in my specialty, we also recertify every year and answer questions again. And we're held to a standard of being sure that we're doing the right thing in our community.
And on top of all of this that you do and all this knowledge you've acquired and that you share and all the changes that are going on, do you still deliver babies and all of the routine healthcare?
I decided early in my career to dedicate my career to the treatment of pelvic floor disorders and surgery. I still offer routine wellness care and screening, and I also get referrals from primary care physicians for other GYN conditions, more general GYN conditions. Those things keep me busy. I haven't delivered a baby in 20 years, over 20 years.
Over 20 years. But that is a very good lead-in to actually talk about the problems or the issues or the condition of having pelvic floor. It comes from childbirth, the issues that we come, right?
In general, yes.
Yeah.
The simple answer is yes. It can affect women even if they haven't had children, but I always think of it in terms of that. In fact, one of the things that as urogynecologists that we're tasked with having is an in-depth understanding of childbirth. Childbirth can be very damaging to the pelvic floor, the muscles and the nerves and the connective tissues. That may not lead to symptoms at all for a patient, or it might lead to symptoms right away. Many patients experience difficulty with discomfort in the pelvis, or loss of urine control, loss of bowel control in some cases, and that can be immediate, or it can be 15, 20, 30 years later. And so it is the childbearing that seems to be the trigger for most patients.
Okay, and so if someone is listening right now who is maybe feeling some of those symptoms, they might want to call you and talk to you a little bit more extensively about what that means.
Oh, for sure. Yeah. It is an extremely common condition, pelvic floor disorders. It affects as many as 40% of women to some degree. And again, it may be very mild and it doesn't impact her life at all, or it might be debilitating. Some patients have a great deal of discomfort, or at the very least they feel self-conscious about what they're experiencing and don't talk about it. It can be a very private symptom and condition that they don't share. So I feel honored to be able to help patients with that, and when they open up to me about it in my office, I feel like I need to be there for them.
Very caring. Tell me a little bit more about what you like so much about caring for your patients.
How much time do we have?
Oh, I love that
How long is
answer.
the show?
As long as you need to talk about that. That's wonderful.
I love going to work. I think the most valuable and reassuring or reaffirming part of being a physician for me has been when a patient tells me that the treatment worked. So if they say, you did good, I hear that. That's a good one I like to hear. Or it worked, or it's gone, or I'm night and day now compared to before. That is really life affirming in a lot of ways, and it's just fun to hear that, and it really I do everything I can for my patients. I'm certainly not perfect, but I do everything I can for them, and so when I hear that feedback, it's really rewarding.
Well, then it must have been even more rewarding to you when you discovered using robotic surgery in 2005. Right? You performed the first robotic hysterectomy in the state of Louisiana? Is that correct?
In Louisiana, that's right. And I'd been involved with robotics since 2002 in my training. Mm-hmm. But in 2005 is when I started offering the robotics here in our area. And at that time, there were very few people doing robotics. And for a number of years, I was the only women's health specialist doing that kind of treatment. The good news is that now awareness is a lot more of robotic surgery is much greater, and robotic surgery involves, the idea behind it is to avoid a large incision for patients and to use small incisions for a broad range of surgeries, and the robotics has really allowed for that in a number of specialties in a way that 20 years ago would have been not really, well, maybe imaginable, but not nearly as common as it is now.
So you've seen even robotics improve and get better over the years itself.
Yeah, I've been involved with robotics in one way or another for 20 years. 20 years this June. And I've used 5 different devices. And the evolution has been amazing, but probably the greatest fun has been the way patients respond to it. When I first started here, when I explained robotics, it was the patients were sort of okay, they were with me, but now before I get the word out there, I already read about it. I saw a video on it the other day this is a true story. I want to say about 10 days ago, I can't quite remember, had a patient with me and I was explaining to them, and I still go in depth, but I started to, and she kind of stopped and said, my husband, who was with her, had his gallbladder out a few months ago with a robot. We know all about it, and patients ask for it now, whereas in the past it was more novel. It's still, in my opinion, robotics represents, with the ability to avoid large incisions, it still represents a really high achievement technologically, but it is novel to me in a lot of ways. But patients seem to be so comfortable with it that's really reassuring to see when they respond that way.
It's interesting how quickly that we can catch up to what you're doing and accept it and just go with it and learn more about it and ask for it.
Yeah.
So for someone who's watching who really doesn't know the whole process of robotic surgery, what happens exactly? Explain to us the procedure and what it looks like in the operating room.
I can say that in general, robotic surgery is, the idea behind it is to avoid a large incision. And so doctors use it for heart surgery, they use it for all sorts of areas. And I can only speak more intelligently about what I do. But the idea behind it is that small incisions are made, small instruments are passed into those incisions to avoid a large incision. And in the case of robotics, what's new about that compared to small incision surgery without robotics, what's called laparoscopy, which has been around for around 50 years, well, the instruments are now connected to a computerized system that the surgeon controls. So we call it robotics. Robots do things by themselves. In this case, the surgeon controls the device. And the device enhances the vision with 3D vision. It enhances the control of the instruments. Whereas with standard laparoscopy or with just my hands, I've got 2 arms. With robotics, I've got 4 arms. And so the hands and the sight of the surgeon are enhanced in ways that are remarkable.
And it's really nice that you pointed that out too, because I've heard it described many times, but that point driven home that robots do things by themselves, which might be a fear of someone who doesn't really understand, that you really are in control. You've just got someone over there that can, this machine that can be more precise, you can see.
That's right. That's
so
right.
Well.
It enhances what we can
Yeah.
do. It doesn't replace it.
Right.
We call it a robot. In a way, it's really, not a complete way to describe the device. It's a computerized laparoscopy, but it just sounds nicer to call it a robot. But robots act on their own, like the one you put on the floor or the ones that build cars. There's people managing that, but they're not controlling the movement. In robotic surgery, the surgeon does the entire procedure, controls the instruments completely.
Okay. So what types of procedures can you do, or do you normally do with robotic
The ones
surgery?
that I focus on are, of course, women's health surgeries. Hysterectomy, which involves removal of the uterus, mesh-free repairs of pelvic floor defects. That when patients have, we talked about pelvic floor disorders, but I'm speaking now of when the organs in the pelvis have lost position, they're falling. Patients can find that very uncomfortable, and so that can be repaired using robotics. And one very valuable part of that for me and my specialty is that there has been some concern about the use of implants to try to correct that, patches, grafts, what's called mesh, which has, a different consideration. Well, I don't use those implants because with robotics, the techniques that are tried and true that just use stitches like we've used forever are much easier to apply with a robot. So that's a big part of my practice. Also for patients who have ovarian problems, lumps, bumps, cysts that can be removed. And in addition to that, from time to time, I'm asked to help patients who have been diagnosed with cancer, who are concerned about of the breast, or who are maybe at risk for ovarian cancer, and their oncologist will refer them to me to have certain surgeries performed to help them with their cancer prognosis.
So much you can do with that.
There's a lot, and the good news is that there's some surgeries I don't offer, but in gynecology there's a whole range of things.
Okay, I think we have a caller.
Oh, wow.
Tiffany, what is your question for the doctor?
Yes, I have a prolapse bladder. Do you work on those?
The answer is yes. There's different, in medicine we use words like prolapsed bladder, fallen bladder, terms like cystocele. These are words that we often don't finish the sentence as physicians, and we don't entirely explain them to patients. The prolapsed bladder can refer to a number of things. That is something I specialize in. That is something that the specialty of urogynecology was developed to try to advance, is more specialized care of prolapsed bladder. Patients can have symptoms like difficulty with urination, leakage of urine, a fallen sensation like something is physically protruding from the private area. It can be very, very devastating for some patients, and that is something that I specialize in.
That's awesome. That's awesome. How do I get in touch with your office?
Well, you can go to my website if you're able to, and preview a number of things there and get my address and a map to my office. The website is WKGYN.
Oh, wait just a second.
Oh, forgive me.
WK. Yes.
Well, let me go ahead and give you the phone number while I'm thinking of it. That might be a little easier. It's Shreveport. It's in area code 318-212-3680, and my website is
3860.
Forgive me, 3680.
3680.
And that's probably the best way to get some information.
Okay, and you spell your name Tibarro?
It's there on the screen. It's Pizarro, but one Z. If you put pizza in there, I get that a lot, and that's one Z too many.
Okay, can you spell it for me?
Sure. Forgive me. It's P like Paul, I, Z like zebra, ARRO.
Perfect. Thank you very much. I appreciate it. I'll get in touch with your office.
It's a joy. Thank you.
Thank you so much, Tiffany, and also thank you so much for your question. And also I want to remind everyone too, with the information, you can go to ktbs.com on our Healthline 3 page. We'll have all the information on how to get a hold of Dr. Pizarro also. So, and if you have any trouble, you can call us. We'll make sure that they get your information. So
there we go.
Thank you again. And thank you so much for calling. I love when someone calls in, because you may be sitting there with a question, you think you're the only one that has that question, but actually this is so helpful for everyone. If anytime someone asks a question, you can just help so many people with that.
Well, it helps inform what someone else might be thinking. And and as we discussed earlier on a couple of occasions, this is what I specialize in, and quite frankly what most of us who do women's health care do, other than delivering babies. We talk about delivering babies and talking about, oh, I had my baby, and that stuff you talk at parties and everyone sends you cards for it. But so much of what we do in women's health is so private, so personal for patients, for women, that it's not something you hear about. However, the things that I specialize in affect millions and millions of patients. In fact, hysterectomy, for example, is one of the most common surgeries in the country.
Oh, wow. Okay, we're going to get back to that. I think we have another caller.
Oh, great.
David, what is your question for the doctor?
The question I've got really is my wife not long ago was sent to Dr. Pizarro through a physician here in Texarkana, Texas. And when she went to the appointment, he didn't even examine my wife. He just...
Oh, sorry, we lost him.
Okay.
Okay. Well, so let's talk about different patients. Is every patient a good candidate for this robotic surgery?
Not every patient is a candidate for surgery in general. So it can be that what a patient is experiencing can be treated without surgery altogether. However, if surgery is going to be done, it might be appropriate to consider robotic surgery. It just depends on the exact nature of the condition and what the symptoms are. So not every patient it's appropriate to offer them surgery in the first place, but when surgery is being considered, robotic surgery should be part of the conversation.
Okay. And what about recovery? What is the difference? How is it, does it matter to, I'm assuming maybe with the smaller incisions, is the recovery, what's the recovery time for something like this?
It depends. In general, I would, if it's a major, we sort of divide things as major and minor. And from the standpoint of a minor surgery, we can call that a day surgery. Hopefully patients should be able to go home the same day and kind of be back to normal pretty quickly. If it's a more advanced surgery, a more complicated surgery, well, those patients, in my opinion, often spend the night. I think they should spend the night, be checked on that evening, and then again the next morning, and then go home the next day. And then depending on exactly what was done, the restrictions I often put are avoid heavy lifting, avoid any kind of real strain to the surgical area, come back in 3 weeks. Patients should be feeling pretty good within 2 weeks at the most. It just sort of but in general, patients should be pretty much back to normal pretty quick.
Okay, I think we have another caller for you.
Right.
Tina, what is your question for the doctor?
Yes, I wanted to ask the doctor, do he do regular gynecology work, just pap smears, annuals, and things of that nature?
I do. I do what we call preventive medicine, wellness screening, and pap smears. I do also do that kind of work, and if a patient has problems with their pap smears, there's also procedures that I offer to help address that.
Okay. Well, thank you. We're considering coming to see you in your office.
Thank you.
That's wonderful. Thank you so much for calling, Tina. And so tell us a little bit more about what patients can expect to prepare for surgery. Is there anything they can do in particular?
I think the most important thing when preparing for surgery is to have clear communication, and for a patient to be really well informed about what kind of surgery she's going to have, why she is deciding to do it, what the surgery means to her, what her goals are, what she expects to see on the other side of the procedure, and to be sure that I've explained everything about the surgery as much as possible from A to Z, from the day before surgery until 3 weeks, 6 weeks after, and that she has the clearest vision of what that surgery will mean in her life. Aside from that, I always encourage patients to stay healthy, watch for anything that would prevent them from having surgery if they start getting sick, and then after, so that in preparation for surgery, and then afterwards, good nutrition, heal up, stay active to stay healthy, but also avoid, and I give a list of instructions. I ask them to follow those instructions carefully.
And we talk about too how much you care for your patients, and communication you brought up, which is so important. And talking about these issues, it's very personal for a woman, and sometimes it's very difficult. Not everyone can talk about it, even woman to woman. Sometimes it's very difficult for someone to ask questions. So, and I'm sure that you encourage that, to feel as safe as possible, come in and talk to you. That's the time to come and talk to you about anything, and to spend as much time as they need, right? Don't worry about rushing through the appointment. Just really feel comfortable about asking all the questions, because it's her body.
That's right. It's super important to try to get as many questions answered as possible. Unfortunately, I tend to be kind of long-winded, and so I often will tell patients what's on my mind and what I think is important. And so when I turn to them and I say, "Do you have any questions?" often they'll say, "You answered them already." And then just to be sure, I want to prod that. I encourage patients to call me if they think of something, like on the way home or when they get home. I often tell patients, "Look, when you leave here, You're going to think of something. Don't turn to whoever's with you and say, "What did he say?" Just call me, because that's when problems can be solved ahead of time, because information really is powerful in the case of surgery in particular. So I think I always encourage patients, because this can be so difficult to talk about, to be as open as they can as early in the process as possible.
Well, those are two lovely gifts, just two of those lovely gifts that you talked about just now, which I'm sure there's many, but with you being able to explain so extensively, it's probably comforting for someone to sit there and not have to keep asking questions. You're so open and lovely with the information that you give, and you've been doing this for so long and very dedicated to it that you really understand patients, and it's nice to be able to sit there and listen for the answers if someone's afraid to ask.
Oh, well, thank you. Well, I think the important thing is that as a subspecialist, I've been doing this, and I've been doing this for so many years, that I try to anticipate questions as best I can and try to provide the information that is valuable for me, so that the patient, and hopefully it's valuable to the patient. Because as we've discussed, sometimes patients are concerned. Well, as I mentioned earlier, a lot of patients don't need surgery. Well, many patients come to me thinking, well, he's going to operate. And when we have the conversation and we find something that can reassure the patient, hey, I don't have to have an operation, that can be rewarding. Later on, that same patient might develop symptoms that are more severe and might require surgery. Well, we've already had that discussion, and so that relationship is built. That's one important thing about robotic surgery, is that because it's minimally invasive, it takes away some of the weight that we had when I was early in training of, well, this patient's going to have a large incision and she's going to spend 3 days in the hospital and she's going to have more risk of pneumonia. Well, robotics takes a lot of that away in many cases. So it really adds to the ability to communicate to patients.
And that's a good point too. Sometimes it's a myth out there. Someone may think, I'm going to a surgeon, he obviously wants to operate, he's going to go there first. And that's not always the case. Like, you don't want to have to you can, but you don't want to have to operate on someone, I'm sure, if you don't have to.
It's important to offer all the options.
Yeah.
I think that there's a bunch of aphorisms that you'll hear as a surgical trainee, but one thing that stands out is the idea that a good surgeon knows when to operate. A good surgeon also knows when not to operate. And no physician is perfect. No surgeon is perfect. No medical condition is always treatable, but we have to try. And so part of that is trying to discern what's, as best we can, what's right for a patient, communicate that to the best of our ability, and have a back and forth with patients so that we can have the best outcome possible for her.
And definitely ask many questions. And don't be afraid to ask you to repeat something if they want to make sure that they heard something. Do you find that a lot of women come in and they think they're the only one who has this problem?
Yes, it happens all the time.
Yeah.
That they specifically, when I say this is common, it surprises them. And part of that, in particular with pelvic floor disorders, things like urinary incontinence or weakness of the pelvic floor, or like that patient, that caller earlier with the prolapsed bladder. Patients, because again, it's not something that their neighbors have told them, or they might have had a relative, but they didn't give the complete story. It's just, and because it's so private and embarrassing for so many patients, it's not something that's part of their common discussion. So when I mention to them that, I just did a surgery for this 3 days ago, they say, really? And that's important for them to know. And so we have to have that consciousness for them as well.
That's got to be comforting too. Mm-hmm. We have another caller for you.
Oh, great. Mary,
what is your question for the doctor?
Okay, I didn't catch the program when it first started, so he may have already answered my question. But I think that I may have a prolapsed bladder, and I wonder what causes that.
The prolapsed bladder, that term, as I mentioned earlier, can mean different things, and often as physicians we'll use that term to describe that the bladder has lost position, that it's falling. Now, the most important thing to know is that can lead to a number of symptoms. For some patients, it can lead to no symptoms, all the way to, for other patients, the feeling that tissue is way out of place, falling out, a large bulge that can be very bothersome and disabling for some patients. Not typically painful, but just constantly bothersome. In between and sort of hand in hand with those things can be other symptoms like urinary symptoms, urinary leakage, difficulty emptying the bladder. A lot of patients report that they have to lean certain ways just to get empty. Low back pain and pelvic pressure can be part of it, but it just depends. And so the best answer is to get a clear evaluation, have an examination to see if something is falling or prolapsed, and then kind of go from there to tailor the treatment. The important thing about that is that if a patient has any number of those things, well, surgery might be necessary, but often not. It can be managed with physical therapy, meaning exercises to re-strengthen that area and help relieve symptoms. It can be treated with certain, there's an appliance called a pessary that is a very common device most OBGYNs use to help lift that area. So it's an insert that can be placed there, and that can be very effective and doesn't require surgery. So it just depends. Does that help answer your question?
Yes, it does, but thank you. I would like to know, though, if a person does have to have surgery to have it reattached or whatever, or if there's something else in there that's causing that, does it take a long time to do that surgery, and does it take long to recover?
The first question, does the surgery take a long time? It depends on exactly what a patient has. If a patient has a very complex, very weak area where the amount of work that needs to be done to replace the tissue is extensive, that surgery can take several hours sometimes, and patients go home the next day. If it's not a very large area, the surgery can be more straightforward, and in those cases, robotics, for example, may not be necessary. As far as recovery, in general, when I do those kinds of surgeries to restore support to the bladder, I ask patients to spend the night. A lot of doctors do those surgeries as outpatients. I've been doing this a long time, but I'm still not ready to do that yet. I still like to see patients recover overnight and go home the next day. And then after that, what I ask of patients, to answer your question about recovery, is look out for anything worrisome like severe pain or fever. Patients tend not to have those things, but look out for them. And then for the first 6 months, no lifting more than 10 pounds. And I'm really strict about this one. A lot of doctors don't do it this way, but this is the way I do it. No lifting over 10 pounds for about 6 months, and then after that, avoid any kind of heavy straining, probably for life.
Okay, and does Medicare insurance cover that?
In general, yes. Medicare is one of the insurances that I accept.
Okay. Okay, thank you so much. I appreciate it.
Thank you.
Thank you so much for calling. We appreciate your questions. So what else, is there something else that we can talk about? What else would you like us to know? We have about 3 minutes left in the program, so.
Well, I think that one of something I'd like to add with respect to robotic surgery is that because it can be applied to a number of things, often patients feel like if they have that symptom that they have to have surgery. I always encourage patients to have a very good dialogue with their physician and look at options, because there are other surgeries that I offer. For example, if a patient requires a hysterectomy, then robotic surgery is a very good option for that. And however, if the patient is experiencing heavy periods, for example, well, there are other less invasive treatments that can be done for that, including treatments like endometrial ablation, which is an outpatient surgery that you can do to help treat periods. So I would just remind patients and to have an open dialogue about what's available and what might meet their goals.
So there's all kinds of alternatives, and if someone chooses, so if they just have this, like say the prolapsed bladder, or is there also, we've also always heard about uterine prolapse too. Is that where the uterus also?
That's right. It's in that family of pelvic floor disorders.
Mm-hmm.
That's right. That's right.
Okay, and so if that happens and someone just decides to live with it, is that okay too?
It can be. If it's not very bothersome, then often conservative options are the best ones, including observation, keeping an eye on things, monitoring things over time to see how we're doing.
Okay. Dr. Pizarro, thank you so much for being here. You've answered so many questions so beautifully, and I really appreciate our viewers calling in, asking such great questions, and thank you for being so informative. So we hope to talk to you again.
I hope so too. It's a pleasure.
Right. Thank you. So for everyone else, thank you so much for watching Healthline 3 and sharing time here with us today. And you enjoy the rest of your day, and we will see you next time on Healthline 3.